Hello and welcome to our talk on part 1 of cutaneous inflammatory diseases. I'm Smita Krishnamurthy, and this is meant to serve as a supplement to your reading in the Robbins Pathology textbook. A basic outline of where we're headed today. This talk is mainly going to deal with acute inflammatory diseases of skin. And by that, we mean these are diseases that usually last for a couple of days to weeks and then go away on their own. So the two acute inflammatory dermatoses we'll talk about are urticaria or hives, and then acute eczematous dermatitis. Now, eczematous dermatitis, there are many different types of eczema. Some of them can turn into chronic diseases. Next, we're going to talk about inflammation of hair follicles in the form of acne and rosacea. Then we'll talk about inflammation of the subcutaneous adipose tissue, which we call panniculitis, and we'll end our talk with some common cutaneous infections. So, urticaria or hives, this is typically what you think about when somebody consumes shellfish or peanuts or something that they're allergic to. This could be drug mediated. It could be like being bitten by a bee, so insect venom. So we have some kind of foreign antigen, which initially causes B lymphocytes to get activated and to secrete IgE. Then when you get re-exposed to that same antigen, the IgE molecules bind to receptors on mast cells and cross-link those receptors. They cause mast cell degranulation. So you get a lot of preformed mediators which are released, and this leads to an immediate type 1 hypersensitivity reaction. So some of these mediators and the things they do are they cause dilation of your vessels, increased vascular permeability, and this results in cutaneous manifestation of what we call wheals. Wheals are raised papules. They can be skin colored to slightly red. They're very itchy, and they usually only last for a short amount of time. If you were to biopsy these, the main finding we see is dermal edema. So if you start at the top, the epidermis is typically not involved in urticaria at all. It's essentially this release of preformed mediators resulting in dilation of blood vessels in the dermis. You can have some inflammatory cells, and depending on the stage of urticaria, this can include neutrophils, lymphocytes, mast cells. But the main finding here is increased kind of pallor of the dermis, and that results from leakage of fluid from your blood vessels. Next, we're going to talk about a condition called acute eczematous dermatitis. So this is a general term which encompasses a lot of different clinical diseases. So atopic dermatitis, which we commonly call eczema, allergic contact dermatitis, like what you see in reaction to poison ivy, for example, irritant contact dermatitis, and drug-related forms of eczema. All of these present in a very similar way under the microscope, but have very different clinical appearances. So the pathogenesis of eczema depends on what type of eczematous dermatitis you're talking about. Atopic dermatitis or eczema is often a IgE type 1 type of immediate hypersensitivity reaction, but allergic contact dermatitis, like reaction to poison ivy or poison oak, is usually a T cell mediated delayed type 4 hypersensitivity reaction. The clinical manifestations are different. Here we're focusing on acute forms of atopic dermatitis, usually presenting in children. You get red raised bumps or papules. Sometimes you can get fluid-filled little blisters, which we call vesicles. These can rupture. They're very itchy, and as patients itch and scratch, over time you get a chronic form of eczema, which is what we're looking at in this picture. It's a plaque or raised area of skin with accentuation of skin lines. We call this lichenification clinically. It's just a result of chronic rubbing and irritation of the skin. And if you were to biopsy this acute manifestation of eczema, what we see under the microscope is spongiotic dermatitis. Spongiosis essentially means that there is too much white space in between the keratinocytes so that the desmosomes which hold these keratinocytes together become more prominent. Now, in the center of this view, you're actually seeing a vesicle, which is what happens when enough edema fluid builds up that you break the connections between keratinocytes. You can actually form a vesicle. In the chronic stage of eczema, which is what we're looking at on the right-hand side of the screen, we get hyperkeratosis. Often the granular layer is quite prominent, not in this particular example, but hyperkeratosis, hypergranulosis, and acanthosis, which is essentially epidermal hyperplasia, and that corresponds to this thickened plaque that you see clinically. Next, we're going to talk about some diseases which involve hair follicles in the form of acne and rosacea. So acne is a very common condition. Its pathogenesis is thought to be multifactorial. People think that the initial lesions of acne actually result from too much keratinization of the infundibular portion of hair follicles. And you remember sebaceous glands normally empty into hair follicles. So when you have improper keratinization, you can get buildup of sebum inside these hair follicles. Another proposed mechanism is androgen excess, because people, when they hit puberty, that's when androgen levels start rising, and acne often develops in those patients. So one mechanism by which this is thought to happen is androgens cause overgrowth of sebaceous glands and increased sebum production. So the increased sebum may be a perfect environment in this plugged hair follicle for overgrowth of certain types of bacteria which are normal colonizers of skin. So when we culture skin of patients with acne, you often find a bacterium called Propionibacterium acnes. This is a normal skin floral organism, but it's thought that it proliferates in acne and stimulates inflammation. So the combination of follicular keratinization, accumulation of sebum, bacterial overgrowth, follicular inflammation can then cause the follicles to eventually rupture, and that usually heals with scarring. So this brings us to the clinical presentation of acne, which we break usually into inflammatory types of acne and non-inflammatory types of acne, although they can both coexist in the same patient. So inflammatory lesions of acne are papules, pustules, and nodules. So let's see what those look like clinically. Papules are just little red bumps. Pustules are white lesions because they have neutrophils in them, and the nodules are kind of larger bumps. Okay, so these are inflammatory forms. And then the non-inflammatory form of acne is comedone. So at the top here, we're looking at blackheads, which are open comedones, and at the bottom, we're looking at whiteheads or closed comedones. And if you were to biopsy these lesions, they look different. So inflammatory papules of acne and pustules and nodules all have inflammation around a hair follicle. So this picture from Robbins is a very high power view of a hair follicle. And normally this structure here, this is a hair shaft. It should normally sit inside the hair follicle, but in this inflammatory lesion of acne, there's been a lot of inflammation. The follicle has been disrupted, and the hair shaft is leaking out into the dermis. So you get giant cells and macrophages that try to engulf this foreign hair shaft, and eventually you're going to have a scar in response to follicular rupture. So inflammatory papules of acne result from either acute or chronic inflammation of hair follicles. Pustules of acne are neutrophilic collections within hair follicles, and the nodules result from sort of this follicular disruption and more deeper dermal inflammation. Now, if you were to biopsy a comedone is essentially a dilated and plugged up hair follicle. So that's what we're looking at in image C here. This is a big dilated hair follicle, and it's got too much keratin. So the open comedones, this is an open comedone. open up to the surface, and it's thought that this keratin and kind of sebaceous material, bacterial breakdown products, all of those things get oxidized, and that's why it looks black, like a blackhead, versus a closed comedone, which would also be a dilated, plugged up hair follicle, but it would be closed with epidermis at the top. Next, we're going to talk about rosacea. The pathogenesis of rosacea is not completely understood, but it's thought that certain antimicrobial peptides stimulate the innate immune system, and toll-like receptor 2 has been found to be activated in patients with rosacea. But the clinical manifestations are very classic for this condition. There are different stages of rosacea. The earlier stages present just with some flushing and redness of the face often, and they can get what we call telangiectasia, which are dilated blood vessels. Later on, patients can progress to getting papules and pustules in rosacea. Typically, they do not get comedones, which is one way you can clinically tell rosacea apart from acne. And over time, over long periods of time, sometimes patients with rosacea can develop a very large nose, which is called rhinophyma. So the pathologic manifestations, the erythema and telangiectasia under the microscope are due to dilation of blood vessels. So when we look at the dermis of somebody with rosacea, you will see dilated vessels. There's often some pallor to the dermis. This is edema. Dermal edema can cause the papules, and you can also get some inflammation. Usually it's chronic inflammation, lymphocytes and macrophages around the hair follicles can cause these papules. If you do have pustules in rosacea, you would have neutrophils within the hair follicles. The rhinophyma is actually a result of too much sebaceous gland hypertrophy. So all these structures are sebaceous glands in a patient with rhinophyma. This is the opening of the hair follicle. Next, we're going to talk about inflammation of subcutaneous fat or panniculitis. The two main diseases we're going to talk about, the first one is erythema nodosum, which could either be idiopathic or it can be associated with certain types of infections like tuberculosis and fungal infections. It can be seen in patients with ulcerative colitis or Crohn's disease, sarcoidosis. Certain types of cancer have been shown to trigger erythema nodosum, and drugs have also been implicated in its pathogenesis. So it's thought to be a delayed type of hypersensitivity reaction to various agents. The clinical presentation is pretty classic. Patients get extremely painful, palpable nodules and papules, usually on the anterior lower legs and shins, but they can also happen on the arms and other parts of the body. If you were to do a biopsy of one of these nodules, the findings are really deep in the skin. So we're talking about panniculitis or inflammation of subcutaneous fat. And when we look at subcutaneous fat, normally there's a very thin kind of fibrous tissue septa that separates these lobules of fat, right? In this patient with erythema nodosum, that fibrous septum is very wide and it's filled with multinucleated giant cells, lymphocytes, inflammatory infiltrates. The type of inflammation will vary depending on the stage of erythema nodosum, but the key here is that it's a septal panniculitis. And by septal panniculitis, I mean that it's this connective tissue septum that's predominantly inflamed, not the fatty lobule out here. Okay, and there's no vasculitis in erythema nodosum. Let's contrast that with another form of panniculitis called erythema ingeratum. It's also known as nodular vasculitis. This is primarily a subcutaneous type of vasculitis, which then leads to secondary infarction and necrosis of the fat, and then inflammation of adipose tissue. So unlike erythema nodosum, which was a septal panniculitis, erythema ingeratum is a lobular panniculitis. So clinically, these patients will also present with kind of these tender red nodules. Usually these happen in the backs of the legs. They can ulcerate. Sometimes they can happen on the shins as well. So the biopsy really does help because this is a lobular paniculitis. Notice, some of these connective tissue septae are also involved, but most of the inflammation is within the subcutaneous fat, not just limited to this the tissue. And then you will often, if you look in these deep dermal subcutaneous vessels, you will see a vasculitis and erythema ingeratum. And a vasculitis essentially means, so here is the endothelial cell. This is the smooth muscle of this medium-sized artery. And you have a lot of inflammatory cells that are surrounding this vessel and also inside this vessel, right? So this is a medium vessel vasculitis plus lobular paniculitis. Erythema ingeratum, we don't really know its pathogenesis. In the past, it used to be thought that it's an immunologic reaction to Mycobacterium tuberculosis, but now a lot of these patients don't actually have TB, but you still want to work that patient up and exclude tuberculosis before diagnosing a idiopathic form of erythema ingeratum. So we're going to end our talk with some infections. Warts and molluscum are caused by viruses. Impetigo is a bacterial infection, and then the dermatophytes and tinea versicolor are fungal infections of skin. Verruca vulgaris is the common wart. When it happens on plantar and palmar surfaces, we call them plantar warts. We have flat warts. All of these are just different manifestations of human papillomavirus infection. Usually the common wart is associated with HPV types 6 and 11, which are the low oncogenic risk types of HPV. And they have a very characteristic look clinically. They are these raised, sort of pebbly, rough bumps. Okay. If we biopsy them, they have a very characteristic look under the microscope. The reason they are raised and rough is because they're hyperkeratotic and acanthotic. And they are also papillomatous, which is kind of this up and down architecture, right? Here is a higher power view. If you look at the granular layer of a wart, it's often very hypergranular, and we get these clumpy keratohyalin granules. You can get some vacuoles developing around the nucleus. Okay, so the nucleus can either be dark and enlarged, or it can be small and crinkled, and you get a vacuole around it. These are viral cytopathic changes of human papillomavirus. We call these cells coilocytes, and they are pretty characteristic of HPV. Now, this bottom picture here is showing you in situ hybridization for HPV DNA, which is one way you can subtype the form of human papillomavirus. Next, we're going to talk about molluscum, which is an infection by a DNA pox virus. And it has a very characteristic look clinically. These usually present as tiny, firm, kind of pink to skin-colored, umbilicated raised papules. Umbilicated means that there's a little dot, a little depression in the center of these little papules, right? So they look so characteristic clinically that usually clinicians don't even biopsy this. But if you did a biopsy, then this is what molluscum looks like. I think it has a beautiful appearance under the microscope. It's this cup-shaped sort of depression with epidermal hyperplasia, so thickening acanthosis, and the characteristic finding is all these pink inclusion bodies. So here's a higher power view. These are large collections of the molluscum virus, which form these eosinophilic intracytoplasmic inclusions, and they often push the nucleus of the keratinocyte out to the periphery. Very characteristic molluscum contagiosum. Next, we're going to talk about impetigo, which is a bacterial infection of skin. It can either be caused by group A streptococcus or Staphylococcus aureus, and it's thought that the organism produces a toxin which cleaves desmoglein 1. You remember desmoglein 1 is the protein that you see in desmosomes in these superficial portions of skin. So the clinical manifestation is or can be a blister in the superficial portions of the epidermis. Clinically, impetigo can either manifest itself as kind of these red macules and papules and pustules, which then kind of erode and then get covered with this honey-colored serum crust. Okay, this honey-colored crust is considered very characteristic for impetigo, and it's just a collection of serum and neutrophils. The other manifestation of impetigo is bullous impetigo, which used to be associated more with Staph aureus. Now, both forms of impetigo are more commonly associated with Staph than Group A strep. But anyway, bullous impetigo presents with these fluid-filled superficial blisters. And if you were to biopsy either form of impetigo, you would see a subcorneal, meaning just underneath the stratum corneum, pustule, which means that we have collections of neutrophils. And here we're looking at a formation of a blister, which corresponds to your clinical blister. And we talked about the fact that it's because of toxin-mediated cleavage of desmoglein 1. So at the granular layer, right, that's where most of the desmoglein 1 is expressed, and you get this subcorneal blister. Next, we're going to talk about dermatophyte infections, also known as tinea or ringworm. So this is a very superficial infection of the stratum corneum, the keratin layer of the skin, by dermatophyte fungi. There are 3 major species of dermatophyte fungi. These are microsporum, epidermophyton, and trichophyton species. The clinical presentation is pretty characteristic. You get these expanding sort of red plaques, and they have a scaly border, right? So we have the nomenclature for tinea is mainly based on where in the body it's located, right? So if you get ringworm on the scalp, we call it tinea capitis. If it involves the body, we call it tinea corporis. If it involves the nail, we call it tinea unguum or onychomycosis. If it's on the foot, athlete's foot, we call it tinea pedis. So it's all the same disease. It's just named differently based on where it happens in the body. And what you can do in the clinic when you see a patient with what you suspect may be ringworm, you can scrape some of the scale off the side of this lesion, put it on a glass slide, put a few drops of potassium hydroxide or KOH on it, and put a cover slip on that. We leave it alone for about 5 to 10 minutes. So the potassium hydroxide just sort of dissolves the skin cells. You can heat the slide a little bit because that just speeds up the action of the potassium hydroxide. And then you can look at it under the microscope for hyphae. We call that a KOH prep. That's something you can actually do while your patient is in the clinic. The other thing you could do is a biopsy, which is what we're looking at here. Biopsy of dermatophyte infections are relatively non-specific because what you normally see is just spongiotic dermatitis, which you see in a lot of different forms of eczema, but you can also see that in tinea infections. This particular case is showing you some neutrophils in the stratum corneum, which can be a clue, but really the only way I know this is tinea and not something else is by doing a PAS stain. This is periodic acid shift stain, which picks up the carbohydrates in the fungal cell wall, and it stains the fungal hyphae in this beautiful pink manner. So here we're looking at the stratum corneum. Hyphae in the stratum corneum equals dermatophyte or tinea infection. We're going to end our talk by talking about tinea versicolor. It's also known as pityriasis versicolor. Notice the word tinea, but this is not a dermatophyte. This is a superficial infection of the stratum corneum by a yeast. It is known as Malassezia furfur. It's a normal colonizer of skin. Another name for the same organism is Pityrosporum ovale, hence the name pityriasis from the Pityrosporum. The clinical manifestation is multiple, slightly scaly, either hyper or hypopigmented macules, often on the trunk. If you were to, you could do a KOH on one of these, similar to what we did with the dermatophyte infection, or you could do a biopsy. And this, we're looking at a PAS stain of a biopsy. Again, this is a superficial fungal infection, but it's a different type of fungus. And this one presents with short hyphae, like ziti or spaghetti, and meatballs, which is the yeast form. So the dermatophyte infection, which we looked at here, tinea, only gives you hyphal elements. Pityriasis versicolor gives you yeast forms along with these short hyphae.